This is the first in a series of webinars and in-person convenings that we'll be hosting in order to share findings from our regional market reports. I'm Dr. Sandra Hernandez, and I'm the president and the CEO of the California Healthcare Foundation. For those of you who aren't familiar with us or our work, we're an independent philanthropy working in California to improve healthcare for all Californians, but with a particular focus on low-income communities and on places where the greatest need continue to exist. These regional market reports are a key part of our work. They give healthcare leaders, community-based organizations, and policymakers key data and information that help them better understand their regions and hopefully to strengthen the unique healthcare system in which they operate. To develop these reports, authors interviewed more than 200 people over the last year to capture on-the-ground perspectives and important trends across the 7 district regions in California. We've heard from hospital executives, we've heard from health plan leaders, we've heard nonprofit organizations, and from community clinics, Medi-Cal managed care plans, and others. We're extremely grateful for the time and perspective that you have lent to this important work. I'm especially excited today for our first report as a spotlight on the San Joaquin Valley, beginning with the core Central Valley area around Fresno. In a moment, I'll turn over the program to Len Finocchio, the lead author of this report, to talk through some of the major findings. After his presentation, my colleague Christoph will lead us in a panel discussion where we'll feature conversations about population health, about operational challenges on the ground, and also opportunities that have emerged in the region to improve care and services. One quick note before we begin the program, we will be hosting Q&A at the end of the program, so please put your questions in the Q&A box on Zoom. And now it's my distinct pleasure to give the program over to Len Finocchio. Len is a respected expert and thought leader in health policy and a very experienced researcher in health research scientist. So with that, Len, let me give the program over to you.
Thank you, Dr. Hernandez, and welcome, everyone. I'm happy to be here today to present the results of my work studying the San Joaquin Valley. Let's see, and my colleague is keying up the slides. There we go. And Ted, you can just move to the next one. So another quick overview of today's agenda. I'll provide a summary of the findings, and then there will be a panel discussion with 4 regional experts, along with Christoph Stremekis from the California Healthcare Foundation. And as Dr. Hernandez noted, there will also be a Q&A session with your questions at the very end. So please send in your questions as we are going along. Okay, go ahead, Ted. An overview of the project. So the purpose of the study is to gain key insights into the organization, financing, and delivery of care in communities across California and over time. This is the 5th round of this study, which began in 2009. The 7 markets in this study include the Inland Empire, Los Angeles, Sacramento, San Diego and Imperial, San Francisco Bay Area, today the San Joaquin Valley, and the Shasta-Lassen region. And I just want to acknowledge that this is a team effort of all of my colleagues who are involved with the study through Yegian Health Insights, and I have a lot of gratitude for all of their contributions to this work. There will be 7 reports for each of the regions, along with webinars or in-person events throughout 2026. And as I noted, those are our panelists for the day. You'll hear more from them after I finish my presentation. Next slide, please, Ted. How did we undertake this? And Dr. Hernandez gave you a big picture overview of how we did this. The San Joaquin Valley includes the region includes the counties of Fresno, Kings, Madeira, Mariposa, and Tulare. And I interviewed 25 regional leaders representing health plans, hospitals, independent practice associations, clinics, behavioral health providers, community-based providers, county government, and other regional experts. Also included in the 7 studies is quantitative analysis done by one of our colleagues, and she used data from the California Department of Healthcare Access and Information, other data surveys, the US Census, and other sources. We also looked at journal articles and news reports. Okay, Ted. And now I'll provide you with kind of a high level background of the San Joaquin Valley, which is home to 1.8 million people. It's mostly rural and agricultural, and several dense population centers, Fresno being the largest, and also Visalia. And the population growth over the past 4 years has been greater than that of statewide. The statewide population growth has basically been stagnant, whereas in this 5 county region, the population growth has been 3%. Compared to California overall, the San Joaquin Valley has a higher rate of poverty and almost twice the unemployment rate. Next slide, Ted, please. Continuing with the high-level background, compared to the state overall, the San Joaquin Valley has a much younger population, more Latino residents, fewer Asian residents, fewer high school and college graduates, and a larger proportion of foreign-born residents. Next slide. And what the data showed us, and also was confirmed by our interviews, was that the San Joaquin Valley residents are generally in poorer health. So the incidence of diabetes and high blood pressure is higher among San Joaquin Valley residents compared to California as a whole. And the infant mortality rate at 5.6 per 1,000 live births is much higher than the statewide average, which is 4.1 infant deaths per 1,000 live births. And this may reflect challenges with maternity care access, which came up frequently in my interviews. However, San Joaquin Valley residents have lower rates of many behavioral health challenges and outcomes such as depression and drug-related emergency department visits and deaths. There is a very heavy reliance on public health insurance. Almost 2/3 of San Joaquin Valley residents rely on public health insurance. So that would be Medi-Cal and Medicare. Over 50% are covered by Medi-Cal, and 62% of residents in Tulare County are covered by Medi-Cal, compared to about 1/3 statewide that is covered by Medi-Cal. In addition, approximately 80,000 San Joaquin Valley children and adults who were lacking satisfactory immigration status were enrolled through the different Medi-Cal expansions by the end of the year 2024. And that is about to change with some of the coming issues with HR1, which I'll talk about at the end. About 1/3 of the residents have commercial insurance, which is much lower than the over 50% statewide average for having commercial insurance. One of the main areas of interest in these reports is, of course, the provider communities. And in this case, with hospitals, some San Joaquin Valley hospitals report financial struggles coming out of the pandemic. And I'll share a bit about the hospitals overall and then focus in on the financial challenges. In this 5 county study region is served by 13 nonprofit and district hospitals. There are no public or county hospitals in this region. 3 hospitals accounted for nearly 60% of the region's discharges in 2023, and that is Community Regional Medical Center in Fresno, Cahuilla Delta Medical Center in Visalia, and St. Agnes Medical Center also in Fresno. The average net income margin, in other words, how profitable a hospital is, their margins vary widely, with the regional average of 2.4%, which is about half of the statewide average of all hospitals. Some hospitals experienced a financial downturn during the COVID-19 pandemic, which happened statewide, and their financial challenges were due to declining inpatient volumes and higher staffing costs. And some of these financial struggles are continuing. Five San Joaquin Valley, I'm sorry, can you go back, Ted? I'm going to talk a little bit about the distressed hospital loan program, which you see there at the bottom. Three hospitals received distressed hospital loans from the state, and I'll provide a little bit more detail on that program. So, five San Joaquin Valley hospitals applied for loans from this state distressed hospital loan program, with three getting loans. Madeira Community Hospital, which got the largest loan of any hospital in the state at $57 million. John C. Fremont in Mariposa County got $9.35 million, and Coahuila Delta received about $21 million. These three San Joaquin Valley hospitals collectively received $87 million, which was nearly one-third of all the $300 million that were awarded across the state to 17 distressed hospitals. Two other hospitals in the region applied for loans but did not receive them, and those are Sierra View Medical Center in Tulare County and Community Regional Medical Center in Fresno. I'm going to spend a little bit of time on Madeira Community Hospital, which many of you or most of you have heard about over the past several years. So after years of financial challenges, Madeira Community Hospital closed in January of 2023 and filed for Chapter 11 bankruptcy protection. Their three affiliated rural health clinics also closed. These closures, including the elimination of emergency department and labor and delivery services, pushed volumes to other hospitals in the region, including Valley Children's Hospital in Madeira, and in Fresno, Community Regional Medical Center and St. Agnes Medical Center also experienced increases in inpatient volumes and emergency department volumes. Camarena Health, which is a federally qualified health center in Madeira, filled critical gaps in outpatient care with expanded or new sites in the wake of the Madeira hospital closure and the closure of its rural health centers. Several hospital systems bid to acquire Madeira Community Hospital, including a partnership between Adventist and UC San Francisco and St. Agnes Medical Center in Fresno, along with its parent corporation, Trinity Health. In the end, American Advanced Management, which reopened the Coahuila Regional Medical Center in southern Fresno in 2020, won the bid and now manages the hospital. And Madeira Community Hospital reopened about a year ago in March of 2025, but without labor and delivery services. And as I mentioned about the role of Camarena Health and how it served the region after Madeira Community Hospital closed, community health centers in the region, most of which are federally qualified health centers, provide bedrock access to outpatient care in the region. The clinics have added more sites and provide more services since the last regional market report in 2020, and more clinic sites are opening soon. Clinics in the San Joaquin Valley serve more patients per capita than clinics in other study regions and compared to the statewide average for clinics. About 77% of clinic revenue comes from Medi-Cal, and they have also been innovative. So you'll hear later from Jason Priest, who runs United Health Centers, and he opened an independent practice association called United Physicians Network to expand access to specialty care, and you'll hear more from him later. There have been persistent workforce shortages in this five-county region, which have persisted since the last report from this region in 2020. There are fewer licensed providers per population in the study region than in California overall. For example, there are 217 physicians per 100,000 in the region, compared to statewide, there are 358 physicians per 100,000. This shortage gap is widest for physicians and behavioral health providers. And also of note, across a majority of the provider groups, the clinician race and ethnicity is not in concordance with 60% of the region's Latino population. And that is to say, a Latino person in the Central Valley is unlikely to see a physician or a provider of his or her race ethnicity. And to address these shortages, there are numerous regional strategies to grow, recruit, and retain the workforce. Health centers recruit and retain employees with higher starting salaries and signing and retention bonuses. And most large providers and even small providers work with high schools, private technical programs, community colleges, and university to grow their own healthcare workforce. The PRIME program, which is a collaboration of UCSF, UCSF Fresno, and UC Merced, plans to expand its training to 50 students and include bachelor's and medical degrees. Most of you know that there has been lots of activity and innovation coming out of Medi-Cal and the Department of Healthcare Services through CalAIM and the behavioral health initiatives. These have been welcomed by regional leaders, but the implementation has been exhausting because of the back-to-back nature of rolling out new transformations, new innovations, and new investments. And I'll skip, given I have very little time left. One thing we asked about in all of our interviews was how all of these experts in the region were feeling about federal and state cuts to Medicaid that were coming and also to other public health programs. And the sense was one of widespread anxiety about the coming cuts and policy changes, especially on the heels of budget cuts that came through last year's state budget. And one respondent noted that this is a tsunami that is coming. Uh, all of the interviewees felt that there would be an increase in the number of uninsured and reductions in both Medi-Cal benefits and provider payments. And you'll see on the right side box there kind of a listing of some of those tsunami changes that are coming through policy and budget. Lastly, at the end of each of these studies, we think through, what issues should be tracked going forward that we heard from our respondents and that we have analyzed through our work and through our interviews and through the data. And I'll just touch on a few here. And the big question, one of the several questions that will be on our minds, well, how will financially struggling hospitals fare through the reductions in Medi-Cal payments and an increase in the uninsured and in uncompensated care? And will some hospitals close? Also, will community health centers continue to expand and further cement their importance to care delivery? And the last slide, Ted. Will these healthcare provider shortages persist, or will the influx of state workforce investments offer some relief? And lastly, how will the region's health status indicators change as residents lose insurance? Those are my findings, and I'm going to hand this over to Christoph Stremekis from the California Healthcare Foundation and to our panel of esteemed experts.
Well, thank you very much, Len, and good afternoon, everybody. As Len mentioned, my name is Christoph Stromikis. I'm the Director of Market Analysis and Insight at the California Healthcare Foundation. I am super excited to be hosting a panel and talking with a panel of local leaders for the next 30 minutes where we can dig into some of these issues that Len mentioned. I'm going to ask our panelists to turn on their cameras and unmute themselves now. While they're doing that, I would remind our audience, we'll take your questions at any time and get to just as many as we can over the next 30 minutes or so. There's a little Q&A box at the bottom of your screen. If you type your question in there, like I said, we'll do our best to get to it. So with that, I really do want to jump right into the content. I would turn to the panel and maybe ask, first question for each of you would be, Len provided some findings overall, synthesizing a lot of different perspectives from the region. But from each of you and the organizations that you represent, what would you identify as the single most pressing operational issue or challenge that your organization is dealing with? Mark, why don't we go ahead and start with you and maybe just one or two words about where you work?
Yeah, thank you, Christoph. So I'm Mark Mertz. I'm the CEO at Kauai Health. We are, excuse me, a comprehensive health system hospital based here in Visalia. And thinking about the results of the survey, I think it'd be remiss to not at least mention workforce and the challenges that we all have here in the Valley in recruiting and retaining talent. We are encouraged here by some recent partnerships that we've deployed to help address that. I think we're heading in the right direction.
Mm.
But on the question more specifically of the most pressing challenge for Cahuilla Health, Len mentioned in his comments that where I'm sitting today in Tulare County, 62% of our residents are covered by Medi-Cal. And so, very clearly for us, the biggest or most pressing issue is the reductions to Medi-Cal, or more broadly to Medicaid reimbursements. The sweeping changes from HR 1 that impact Medicare, Medicaid rather, eligibility, enrollment, and financing, really more than just the most pressing issue of this study or this year, to me is probably the most challenging issue that we've faced in the last couple decades, which I don't think I need to remind anyone on this call that included a worldwide pandemic and healthcare emergency. So for us, really, more specifically from HR 1 for us is the reductions and the eliminations in the supplemental payment programs that really allow us to serve this high volume of Medi-Cal patients in our communities. As we look at the full impact of the bill being implemented over the next several years, it is tens of millions of dollars in reductions in revenue for us. And so what Cahuilla Health is doing is probably not dissimilar from what other providers are doing in the Valley or across the state, which is really revisiting our strategic and financial planning to adjust to this new reality and make some decisions that in many cases are difficult. To answer some of Len's questions he asked towards the end, I do believe that hospitals will close as a result of these changes and reductions to Medicaid. But what is abundantly clear to me is that Cahuilla Health or other organizations and providers that serve a high volume of Medicaid patients like we do, we absolutely cannot absorb any additional reductions in payments for lower income patients who really do need us the most. And I'll close with quite frankly, Congress can't fix the federal budget or balance the federal budget on the backs of these low income patients who really do rely on us to be here.
Yeah, thank you, Mark, for that perspective. There's a lot of threads there that I want to pull on over the next half an hour. So just appreciate your getting us started. I might turn next to Ava. Ava, could you maybe just introduce yourself very quickly in your organization? Then, what is, if you had to identify one, what would be the most pressing kind of operational challenge your organization is facing right now?
Yes, thank you, and good afternoon, everybody. Eva Terrazas, Chief Public Policy and Advocacy Officer with Pacific Clinics. We're a statewide community-based organization that serves some of the most vulnerable children, youth, and adults in our state's Medi-Cal system. We provide services to Medi-Cal enrolled individuals across the lifespan who have complex health conditions and engage in a multiple delivery system to access care. As many of you, most of our clients live in communities that have been marginalized and impacted by poverty and injustice, and folks who understandably have a hard time navigating our fragmented and complex system of care. I think that just about anybody who works in healthcare is concerned about the looming impact of HR 1, and you'll probably hear it more and more, not just in this forum, but in other forums that we attend, and its effect on timely access to care, health outcomes, the financing to support an organization's viability to deliver or contract out service. That, coupled with the anti-immigration harm and trauma being felt in the communities, that is really preventing individuals and families from seeking safe and affordable services. So a big question many of us have is, how can we minimize the impact to individuals currently enrolled in Medi-Cal with work requirements and Medi-Cal eligibility redetermination set to begin next year, And that could impact anywhere between 1 to 3 million people in California losing coverage. And then how do we sustain the investments the governor has made in behavioral health, which is about 50 billion over the past 5 years that have created transformational change in the health system and in the communities we serve?
Thank you, Ava. There's a lot there too to really dig in on. Really appreciate you kind of getting us started and providing your initial perspective. Justin, why don't I turn to you before we get to Dr. Paul? But could you, introduce yourself and your organization, and then if you had to prioritize, what would be one specific operational issue, from HR1 or any other thing in the environment right now?
Sure. Thanks, Christoph. Yeah, Justin Parise. I'm the CEO for United Health Centers of the San Joaquin Valley, federally qualified health center here in Fresno, Kings, Tulare, and Kern County. Fairly large, almost 200,000 patients and about 40 locations. So we serve a very wide area of the valley, and I think I can really ditto to what Mark said in a lot of ways. I mean, we have so many challenges, but really the biggest one is we're just trying to get our arms around what's coming, especially in 2027. There are some changes this year that we're dealing with, but with all the impacts of HR1, in addition to, while people are losing coverage potentially, we're trying to gauge exactly what that impact is going to be, because we don't exactly know. And then on top of that, with the impacts of Senate Bill 525, when you talk about workforce, as Lynn said, it's a tsunami. It's that kind of perfect storm where we are going to have more uninsured patients. And I've said this before, there's really only two places for uninsured people to go, and that's to fairly qualified health centers and hospital emergency rooms. And we don't want them going to hospital emergency rooms. So for their primary care services, it's going to fall on the backs of the FQHCs to take care of them in that setting. And then the massive salary increases that have happened over the last couple of years and will continue to happen into next year. It is that perfect storm that we're just trying to get our arms around and figure out what the exact impact is. For the FQHCs, there's so many things that we do or that are already not reimbursable. All of the enabling services that we provide, all of the different programs that we have for patients to take care of them, and so many other needs they have outside of just a provider visit. Those things are really at risk with a lot of these changes that are happening. So that really is the most pressing issue I think that we're dealing with here.
Really appreciate that perspective, and I'm looking forward to digging in with each of you about, each one of you about really what are some of those difficult decisions that you're going to have to make? What are the consequences of some of these changes that are coming down? But before we do that, I want to turn to Dr. Paul and maybe broaden the question a little bit, given your role as Chief Public Health Officer there. Could you, if you were thinking about the region as a whole, could you name, the most pressing population health challenge, in the region? Or if I ask you that question, what is it? And then can you provide any perspective on the root causes of that challenge?
Well, we may end up in the same place. Public health departments all do their community health assessments, and a lot of the counties in the Central Valley come up with similar issues like chronic disease, substance use. But I think every county really has identified access to care and provider shortages as a really critical issue for this area. And when you see that as a critical area, what's the biggest priority in the next few years? The biggest area at risk for change and getting worse, I think, is access to care related to the coming changes to Medi-Cal enrollment. And people are mentioning about the coming changes, but it's already changing. Madera County's gone from 75,000 down to about 70,000 enrollees. And I think once people know a program is going to change, they already start feeling like, well, I probably won't qualify. And we're already seeing enrollment dropping. But what's been frustrating to me is there's been a lot in the news about the Affordable Care Act, subsidies going up, and that's been all over the news, but there's been very little about the changes coming to Medi-Cal. I think that's because the one story is sort of simpler and the other story about Medi-Cal becomes much more complicated. But the reality is the people on Affordable Care Act subsidies here is, 1 or 2% of the population. And as people have said, and as in the report, it's 50 to 60% of the population here on Medi-Cal. And there's several reasons why it's complicated. And it's funny to me because there's a lot of parallels with when Madera Community Hospital closed, right? People were looking for and thought that would be a simple story. A hospital and emergency room closed, there's going to be people, dying of trauma on the steps. But we're part of a complicated, health system, health environment. And a lot of people were able to step up to mitigate some of those challenges, but not all of them. EMS kept response times the same. As you mentioned, Camarena did a great job expanding urgent care and bringing in specialties that we were losing with the hospital. And obviously the hospitals in the area all had to step up. But the one thing that didn't happen with that was that people didn't lose their coverage. So at least these people who stepped up and were trying to see more patients and increase their capacity were able to get reimbursed for some of the care that they're providing. But it was a huge loss of access. So who got impacted, right? It wasn't necessarily the trauma patients and it wasn't sort of lower acuity people. They had some impacts, but I think the biggest impacts were people with things like poorly controlled heart failure, poorly controlled diabetes, who would have gone to the local emergency room and now delayed care. And those people are going to end up much sicker 2 or 3 years from now. But it's not a simple story to get across. And I think the same thing is going to happen with the loss of coverage. There's financial impacts and there's health impacts, right? So when people lose Medi-Cal, if you're in a horrible accident, you'll still get to the emergency room and get the treatment you need. You may not get the rehab you need afterwards, but you will get the acute care that you need. You may be financially devastated afterwards. It may be a big loss to the hospital. And at the other end of the spectrum, if you've got a horrible flu, you can pay your $25 sliding fee scale and get, the treatment you need at a clinic. But there's a lot of people in the middle who are going to be severely impacted. I see people, they have Medi-Cal, very few resources. Maybe they get diagnosed in Fresno County with new cancer diagnosis. They manage to get care. They have visiting nurse services. They manage to get their chemotherapy. If they don't have Medi-Cal, the delays that are going to result from applying for disability, applying for Medi-Cal, trying to apply for indigent coverage if that exists in the meantime, prior authorizations to be seen outside of your plan, all of those things are going to lead to delays to care. And that's the difference between timely chemotherapy and doing well and not getting your chemotherapy on time and ending up in the hospital on, salvage or palliative chemotherapy. And that's a complicated story for one reason. And the other problem is it's this difficult story to tell because there's always a reason why it's somebody else's fault they aren't getting care. If they had filled out the right form in time, if their doctor had done this and done the right prior authorization. So there's going to be a huge loss of money coming to this area for care. There's definitely going to be cuts in access, and it'll be very difficult to make a nice, clean story about, who's responsible, why isn't this person getting the care they need? So I think it's going to be a huge impact in this area. I don't think the counties or the states have any ability to make up the difference in money coming into healthcare that we're going to see. I think it's a pretty sort of scary, frustrating time looking ahead.
I really appreciate the perspective, and I have to say those are very sobering kind of comments, and I think we'll have a chance to dig into that a little bit more with you over the next half hour or so. I'll just remind our audience we've got a lot of questions that are coming in to keep those coming in by Q&A, and I'm going to kind of go one more round through our panel before we get to all of those. Mark, I want to go back to you and maybe dig in specifically about something you alluded to around strategic planning that you're going to need to go through and difficult decisions that you're going to have to make in the wake of some of these Medi-Cal cuts. And I'm reminded, of course, of something Len mentioned, which was the Distressed Hospital Loan Program and the financial challenges that Cahuilla went through 4 or 5 years ago. And I know you had to make a lot of very difficult decisions then. And so my question for you is something like, what were, some of those decisions that you had to make over the last 4 or 5 years, those difficult changes? And what are you anticipating specifically within Cahuilla Delta? Is it loss of service lines, changes in operations? What is going to happen, or what are you projecting you're going to need to do over the next couple of years, given some of these cuts that are coming?
Yeah. Just to kind of put a finer point on those financial challenges. So prior to the pandemic, we were, a very sound and successful financial organization. Obviously, the impact, the pandemic was devastating for all of us with the closure of elective cases, the high cost of supplies, the high cost of contract labor was all was all devastating to go through, which did result in the distressed hospital loan that we did receive, fortunately. Coming out of that, however, we kind of got back on our feet and we're headed in the right direction. And then, kind of the perfect storm that Justin referenced with Senate Bill 525, which is a huge impact to us. That was the statewide minimum wage for healthcare, and now staring down the barrel of these HR1 cuts. We're looking for tens of millions of dollars to backfill or to find, right? And so the more fun answer is, well, we're going to grow our way out of it, and we're going to look for new services to bring. But the frank reality is we've got to look at everything. We've got to look at becoming more efficient. We've got to look at doing as much or more with less resources and all those things that entail. Going back a few years, we had to close skilled nursing beds. We had to close a neurosurgery clinic, things that, this community really desperately needs, and no one's coming here to provide it behind us. But frankly, you got to look at the things that are not sustainable financially, and you got to make really difficult, gut-wrenching decisions accordingly. In the past, we did do some reductions in positions. We're not doing that currently. We're hoping not to do any more of that, but it doesn't make the other decisions any, less difficult.
Thank you for sharing that. And I promise we're going to get to some more uplifting questions and conversation
Thank you.
in just a few minutes here. Eva, I want to turn to you, and you mentioned some of the some of these changes around work requirements and eligibility redeterminations and state investments in behavioral health. But can you share anything specifically about how is your organization? What sort of decisions are you having to make now in order to adjust to some of these changes that are happening and are already coming?
I think that Mark raised some of the issues that most organizations are engaged in right now, taking a look at cost efficiency measures, doing financial forecasting. The truth is there's still a lot of ambiguity across systems on the full impact of HR1. And we are working closely with our state and county partners to understand the extent and the impact on their budgets and the downstream effect it will have on the community-based provider community. So for example, just this past week, the California State Association of Counties released a policy brief stating that counties will lose up to $9.5 billion annually. So counties will be under considerable strain to balance their budgets. And most of our work is directly related with counties. We operate in 5 geographical regions throughout the state. So we have many contracts with counties throughout the state to deliver behavioral health services and child welfare services and early education. And so many of the cost-saving measures that were spoken about earlier are things that we are actively engaged in and trying to create efficiencies for our staff. And how can AI help reduce some of the administrative burden that we experience that leads to burnout and workforce shortages? And then how do we create other efficiencies within the agencies in order to be able to navigate these turbulent times?
Yeah, thank you for sharing that. Justin, I want to go to you and maybe like asking a similar question, but in a slightly different way or with a different slant. Can you talk about, some of the ways that you and your organization are responding that excite you, or is there something you're particularly proud of or excited about kind of in this moment and the way that you're responding to some of these obvious pressures on your organization and the region?
Yeah, and Lynn touched on it earlier, one of the things we've done in the last, I think we've been up 2 to 3 years now, is we did start our own IPA for our patients, and we have about 150,000 Medi-Cal patients in our IPA and about 10,000 Medicare patients. And really the intent of that was to do a couple things. One, the most important thing was to attain better access for our patients for specialty care, and be able to have a much better panel that could serve our patients. And then the second thing was to help control costs. if we could achieve those two things, it was going to be a great thing for not only for patients but for the system in general. And I think we've done a pretty good job with it. We have a very developed panel of specialty providers, and we're able to really do a better job of helping manage our patients' lives. But we still need good partners. We're not at risk for inpatient care and things like that, so we have to have really good hospital partners, especially to work with, to make sure that we've got, really good access for our patients for those things that are outside of our scope.
Thank you for sharing that. Dr. Paul, sort of last question before we go to the audience here is for you, maybe similar to the question that I asked Justin. Could you, name maybe one initiative sort of in the region, dedicated to improving healthcare or, population health, that you're particularly excited about?
Yeah, this is a positive. It's a bit of a shift. The county here got funding from the Strategic Growth Council from the state to build a community resilience center, and we're super excited about it. So it's a new building. It'll be an emergency shelter. It also has space for people bring their animals. We learned that through the fires. You can't get people into a shelter if they can't have somewhere to take care of their animals. It'll have a media center, kitchen, gardens for educating people about nutrition and also for workforce development. It's also going to co-localize behavioral health and public health for prevention. So it just, like I said, it's this real bright spot for us. I have to credit Sarah Poss, our director, for pushing it through. But it's really exciting to have one thing that's not being cut, and it's actually growth and actually works with upstream things, trying to keep people healthy. And so we're really excited about that.
Yeah.
Christoph, can I jump in on that
Yes,
question?
please.
So, as part of the CalAIM initiative, we are providing enhanced care management and community support services in the San Joaquin counties identified in the report. And that includes housing navigation services. It's an important service to help clients navigate our complex and fragmented system I spoke about earlier. Housing deposits, which is a funding source used for housing deposits and other essential costs to move into a home, and day habilitation that support people at risk of homelessness or are currently unhoused. And so far, our data has shown positive outcomes with client adherence to care plans, family engagement, which is really critical, and referrals to specialty care and community services, that those appointments are being kept. And so these are truly impacting the lives of the folks we touch with these services.
Really appreciate you sharing that. We have so many questions from the audience, and so I want to make sure we can get to some of those. There's a couple questions in here about some of the Medi-Cal changes, specifically to folks with a certain documentation status or undocumented Californians. Len mentioned this in his presentation, but there are some pretty significant changes around benefits, benefits that are being offered, of freezing those benefits, and then freezes on enrollment. And so, each of you, mentioned HR1 in one way or the other, but could one of or a few of you put a fine point on what sort of fallout do you anticipate for the region, given the elimination, for instance, of dental benefits in Medi-Cal for undocumented adults starting this July, or these new copays that are going to be introduced in 2027. Maybe Justin, do you have any thoughts on that one, and then we'll see if anyone else wants to weigh in.
Well, I mean, it's with our undocumented, patients, it's going to be what it was before they qualified for Medi-Cal. They're gonna, in my setting, they're going to be on our sliding scale program, where they pay a nominal fee to get services, and that's what's going to happen is a lot of people that right now qualify, that are undocumented, will not qualify soon, and we're going to still take care of them. We're just not going to get a whole lot of revenue to take care of them, but we will still continue to provide services to them.
Dr. Paul, or anyone else kind of want to, or Mark, do you have a thought?
I'll maybe just add that, prior to the expansion of the Medi-Cal program in California, we probably had up to 12% of our patients that we would see essentially uninsured. Today, that's below 1%, because most people can get Medi-Cal. So that's going to change. Someone mentioned it earlier. I'm not exactly sure where it's going to go. I don't expect that uninsured number to get back to, the 10 or 12%, but it might get halfway back there just with the different eligibility requirements. The very onerous redetermination, the fact that, folks are going to have to re-sign up every 6 months. We're investing in additional staff and resources to be able to help enable that, to get people who can get re-enrolled, whether they're in the ED or they're out in the community. How do we help them, retain those benefits that are important to them?
Yeah, I think the first point that Justin made is whether people are undocumented or documented, if you don't have insurance, you can go to an FQHC or an emergency room, and that's where people are going to get care. And the other thing, if you want to see what's happening, is you can look at states that didn't expand Medi-Cal eligibility. And I think their FQHCs have, 25 or 30% of their patients are uninsured. So there's you can already kind of see, and I think they have much lower income and are much fewer services and much less able to expand. So that's my sense of the question you're asking before. And it's important because a lot of people talk about, oh, well, county indigent programs cover undocumented people. Where are they going to fit in? And I think the reality is all uninsured people will have access to care at FQHCs or hospitals. And the issue there is going to be the huge financial impact of that change as those numbers go way up.
That's a great point that you make. And I think related to your prior comment, Dr. Paul, is that it's a complicated story to tell, right? When HR1 was being debated and being announced and discussed, people talk about we're going to take away benefits from people who, quote unquote, didn't deserve them or shouldn't have them. But what was lost in those conversations, at least the ones that I saw, is well, that directly impacts those clinics and those hospitals because it's not like people are getting a check every month from the Medi-Cal program, right? They're getting coverage, they're getting access to care, and that money is going to pay providers for providing services to them. But to a large degree, they will continue to get services. We just won't get paid for it. I didn't hear much of that in the dialogue.
Ava, I want to go to you as sort of our next question from the audience, and this one was around alignment. Could you, maybe do you have perspective on where is the largest opportunity for alignment between plans, counties, and CBOs to address social determinants of health at scale? Any thoughts on that?
Yeah, I lots of thoughts on that. One of the challenges that we've experienced is with administrative requirement, that is with rate and reimbursement under managed care plans. And so for many behavioral health and crisis services, managed care payments haven't kept up with staffing costs, acuity of the needs of our clients, or the expectations placed on nonprofit providers, which makes it hard to sustain access even when plans in the state would like to expand programs and services. So nonprofit providers continue to navigate plan-specific rules, prior authorization, duplicative documentation that consume time and resources and ultimately reduce clinical capacity. And so for us, it would be helpful that alignment begin with the Department of Healthcare Services, who has oversight of managed care plans, so that it would require working closely with our policy associations who represent us and other CBO providers to understand the depth and breadth of challenges we are experiencing. Because while these have all been wonderful programs and there have been impact, there have also been challenges where the alignment isn't quite there, and we still need more work to get to that greater place of alignment.
Appreciate that. Dr. Paul, I'd be curious in your perspective on this sort of, big picture population health level, when you sort of look across plans, counties, CBOs, where's the biggest opportunity for alignment when it comes to SDOH?
Well, I don't know, and I'm still kind of thinking about the last question as well, too. And when we say that, people are going to be able to get care at these places, I think that's also going to lead to a lot of dead ends, which is the people with more complicated issues, right? You'll get the initial workup done, but you'll need specialty care and more complicated care, and that's where it's going to fall apart. You'll get your dental evaluation, and you need something that's complicated in surgery, and that's going to get delayed. Kind of what Eva was mentioning, there's sort of more and more prior authorizations and requirements. And the route not to go down, our medical system is fairly inefficient. And when money gets decreased, the usual response is to make it even more efficient so that people don't get care, right? You add in layers of prior authorizations and requirements so that nobody ever gets what it is they were supposed to get rather than trying to make it more efficient. And even now you hear, I see messages going around, our county's going to reopen clinics and things like that. Like if we have less money, we have to have the most efficient system we can. And what we have efficient now are things like the FQHCs. The thing is, how do you support what we have on the ground that is now working and is efficient rather than trying to make it less efficient to cut costs or by trying to create some alternate structure that just isn't going to be able to provide the same kind of, medical care is very different than the last time we had a large indigent population. It's much more streamlined, efficient. People are starting to use AI. You can't look back to what we were doing, 15, 20 years ago to help care for the indigent as a solution for what's going on now.
Thanks for that. You mentioned sort of an area that one of our audience members asked about, which was specifically AI. So I want to go to Justin with this question first. Can you talk about ways that your organization is using AI to reduce administrative burden or become more efficient, reduce burnout? What are you doing anything right now? And if no, have you looked at any of these tools, and where do you see the most potential?
Yeah, I mean, we are using AI. I have to admit, I'm a little bit scared of it. I watched Terminator the other night, and so, but we use it in a lot of different applications. One for providers and helping them to be more efficient with charting and seeing patients and making the paperwork less burdensome for them, because there's a lot they have to do in just a single, simple outpatient visit. So that's one important application. And then also in patient engagement, how we interface with patients. And at some point, you can only bring on so many people to answer phones and do those things like reminder calls and all those different ways that we engage with people and outreach to people. So I think we are all trying to leverage the technology to become more efficient, but the technology also is not cheap. And so we're contending with that also. We want to be as savvy with the technology as possible, but we also have to pay for that technology. And so it's not that easy to just go out and say, hey, let's get this and implement it, and it's that easy. I mean, there's a lot of work that goes into doing those things, and it takes people still to design it and implement those things.
Yeah, that makes sense. Mark, how is Korea using AI? Is that part of the solution, in terms of like getting to a more sustainable financial trajectory?
Yeah,
Um,
I'd say we're dabbling in AI. I think similar to what Justin described, we do have ambient listening throughout our clinic. So physicians essentially, there's devices listening to their conversation with the doctors. It's capturing that documentation. The physicians then review it and sign off on it. The reviews from physicians has been overwhelmingly positive, that it reduces their documentation time, helps them remember things that maybe happened during the course of a natural conversation. We're looking forward to seeing how that might be applied inside the walls of the hospital, whether it's with nurses, whether that's with physicians on the units or in the emergency department. That's probably the biggest use right now. We are looking at other areas, revenue cycle. I think payers are using AI to deny us payments. I'd like to deploy some AI technology to help counter those efforts. And finally, looking at some call center solutions to help supplement our call center staffing with agents that are able to handle the easy stuff.
Thanks for that. I could talk to you guys all afternoon, but unfortunately, we have time for about one or two more questions. And so we'll go. There's a question here from the audience specifically about primary care, or what needs to be done specifically to bring more primary care to the Valley. Definitely want you to weigh in on this, Justin, but maybe we'll start with Dr. Paul. Kind of anything that sort of top of mind. What can help, in this area?
Well, I think there's been a lot of progress. People always assume there's no primary care, but I think what FQHC's, the system that's set up has been a miracle for improving primary care, right? And the other two big things are the UC Merced, San Joaquin Valley Prime, and the Clovis Health Science University are graduating a lot of people who are going into primary care. So yes, we're still short compared to other parts of the state, but I think that's just been a big, actually positive in the last, 20 years that I've been here. And the problem is you have to have specialty care as well, right? If otherwise it's the same thing, you just end up with these dead ends. You can do the work up to a certain point, and then they need a cardiologist, a gastroenterologist, a dermatologist, and those are some of the hardest positions to fill in this area. I mean, the others can speak to that better than I can, but whenever I hear primary care, I'm like, there's FQHCs popping up everywhere, right? But the lack of access to specialists is becoming a real, from my perspective, just a real, block to, people getting the more complicated care that the primary care often shows that they need.
Justin, would you, just quickly, that's a long conversation, but would you agree with that? Maybe the access to specialty care is, you know,
I,
uh,
I do, and I think it's even a step further than that. It's making sure you educate the public and people about when they need to go to primary care and when they need to go to the hospital. I really like Mark a lot, but I'm sure he doesn't like taking care of people that don't need emergency services in his emergency room. So we take that very seriously here. It's our job to keep people out of the hospital and keep them out of the emergency room. And no matter how much education we do, no matter how much we try to educate, the public and be active in that, people still wind up going to our emergency rooms when they don't need to. And you get situations where, I know at community downtown, it's like a war zone when you walk down there. People lined up in hallways and they're doing their very best. But how many people are going in there that should not be there? And so I think that's the key in it, is that we have put all these locations in, and myself and my peers that are out there, and we're trying to be accessible. So don't go to the hospital unless you need to. That's the key in it.
And I think I'll just chime in. I think that's one of the, nobody quite knows how to do it, but most promising or interesting uses for AI is helping people make those kind of decisions. And nobody wants to let it loose because sometimes it's wrong. But the information people can get about their own health and whether they can get to an emergency room, how they should apply for a sliding fee scale, all of that stuff is just so answered at an incredible level by AI programs. But again, people are nervous of telling everybody to use it because occasionally it's wrong.
Mhm.
fascinating. Would love to talk more about this, but I think we just have time for one more question. And maybe it's something like this. Len mentioned we've been doing these regional market reports through the foundation for the last 20 years or so now. And so I want to take you sort of looking into the future, 20 years from now, when we're on our eighth or ninth, Fresno area regional market report in 2046. So we're 20 years from now. Where are all of you most optimistic that the region is going to have made some progress when it comes to health and well-being in the region? And given time, kind of need like 2 or 3 words on this. Where are you most optimistic progress will happen? Ava, do you have any thoughts?
In just 2 or 3 words, I would say breaking the cycle of generational poverty in the valley, which will lead to increase in economic stability, greater educational outcomes, and better long-term health outcomes for families in need.
Thank you for that. Mark, maybe 20 years from now, where are you most optimistic when it comes to health and well-being in the valley that progress will be made?
I'll go back to where I started with workforce. And I think I saw some of the comments that came in through the Q&A. There's some phenomenal work being done in the Valley to train professionals for healthcare, whether they're nurses, whether they're surgical techs, occupational therapists, or physicians. I am excited about some of the work that we're doing to kind of build and train your own, creating pipelines that start in elementary school and follow through, whether it's an associate's program or a college or a medical school or residencies. I see huge potential. It's a long-term investment though, right? It's a 2-decade bet. I'm excited by it.
Justin, 10 seconds. Where are you looking for progress
Well,
in the next 20
Mark
years?
stole mine, so I'll tell you. The other thing I had kind of jotted down was the better coordination of care. We've come a long ways, and even in the last decade, as far as how the information is available and what you can get easier, and the coordination of care has gotten better, but we are still really fragmented. A lot of us, we're all on different systems. Some of them talk well, some of them don't, and so that's really what I want to see, is because in the end, it's so much better for the patient and their experience and their care.
Thanks. Dr. Paul, you get the last word, sort of 10 seconds, 20 years from now, where is the most progress in the region?
Well, two things. I hope medical education, which leads to medical research, that really brings in a whole different infrastructure. And I think that could help a lot with provider shortages and access and just economic benefit to this area. And the other one is that, I think the system is becoming, something better will rise from the ashes of what we're currently doing with our medical system for coverage for people and savings accounts. It's so complicated that somehow this will lead to momentum enough to come up with a system that's just more workable and more efficient, and lets people get the care they need.
Thank you so much. Well, unfortunately, that's all the time we have for today. So I'm going to invite Len to turn his camera back on while I thank everyone for participating. Thank you, panelists. Just a fascinating discussion. And thank you, Len, for those findings. Thank you to all our audience members for joining us today. Really appreciate all the questions. And I'm so sorry. There was just more than we could handle in the time. Just quickly on logistics, the recording of this webinar, the slides, the long report, which I encourage you to read, that's all available on our website, will be available on our website at chcf.org. Our next regional report on Shasta and Redding counties is already published on the website. We'll be doing an event there in person on April 2nd. And then finally, there is an evaluation of this webinar that'll pop up on your screen. Please do take the time to fill that out. We really do look at that feedback, and it will help us make future programming better. So with that, thank you again to all our panelists. Thank you for all the participants for a great webinar today. We'll see you next time.
Thank you.
I know.
Thank you.